today's echo session that we're going to have, and I'm pleased to welcome Dr. Patrick Kabwe, Chanda, who is calling in from Addis Ababa in Ethiopia. He will be able to give the rest of the introductions as we give him an opportunity. We had a very great presentation last week, and we were talking about mental health. And Dr. Naim was here, and he did discuss quite a number of things regarding mental health. I think some of the important things that came out is that we actually have there's need to actually support our health workers in mental health related issues, and that there is need to actually provide the psychological first aid. And so that came out as one of the key issues, and also that we needed also to be able to assist our patients that we are seeing, the people that we're isolating in those isolation facilities, to support them psychologically. So some of the very few things that I was able to pick up from that are quite important in the COVID response. So today we have an opportunity to listen to Dr. Patrick Kabwe as he shares with us some of the experiences from China. I think some of the things we've seen, but some of the things are new. And this will also position us in a way to be able to address some of the critical issues that we're seeing happening in our response currently. So we've got issues that are coming in of facility screening, some cases being detected in facilities, healthcare workers are getting infected. What are some of the lessons we can pick out from the China response and how they addressed some of these issues? So thank you so much. We do have some experts that have joined in, and then we'll be able to just invite them to speak as well. So Dr. Chanda, could you please go ahead and introduce yourself and just tell us about what you're talking about today.
All right. Thank you, Dr. Kozia, and good afternoon, everyone. So my name is Dr. Kabwe. I'm a field epidemiologist currently based at the African Union headquarters with Africa CDC, helping the response to member states against the COVID-19. So we'll basically talk about some of the experiences that we did pick from China and Italy in terms of the way they did manage COVID-19. So basically, what are the learning objectives for this echo session? So the first one is we need to describe the epidemiology of COVID-19. The second one, we want to also describe what the non-pharmacological interventions of COVID-19 were implemented in these nations we're referring to. Also want to understand the case stratification of COVID-19. Also to understand the different antiviral treatment options for COVID-19. And of course, we want also to look at how did these countries help to cut down on healthcare associated COVID-19 infection. Next slide. Okay, so we'll give a background of how the COVID situation evolved. So basically, the first 4 cases of pneumonia of unknown origin were reported in Wuhan, China on the 29th of December, 2019. And by 31st of December, the World Health Organization notified, China notified the World Health Organization by the 31st of December. By the 7th of January 2020, the Chinese scientists had actually isolated the novel coronavirus from 3 patients. Later on, the World Health Organization later named the coronavirus infection causes COVID-19. So the whole thing was named to COVID-19. And on the 11th of March, the World Health Organization declared COVID-19 a pandemic. So this is a brief history on how this outbreak evolved. All right, so we look at the epidemiology of COVID-19. So one of the key things that we need to understand is that from the studies that were carried out in about 38,000 close contacts it was found that about 1 to 5% of these actually did develop COVID-19. So basically, we are saying the majority of cases arise from close contacts. So other studies that were done in China indicated that the disease, were running within families. So there was a familial clusters in about 75 to 85% of the cases. Then in terms of secondary household attack rate, so here we're looking at how long it will take in terms of a primary case causing infection in another person. So early on in the outbreak, this was seen to be 10%, but with rapid isolation, which were instituted by the Chinese government, this was reduced to about 3%. Then transmission in close settings, according to the Chinese experts, they're saying it was happening, but they didn't have, this wasn't really a major driver for this. And those close settings included health facilities, nursing homes, and prisons. So they didn't see much of cases at that time in terms of infections in these close settings. Then transmission in schools, this had not been observed. And one of the reasons for that was the schools were actually closed earlier on. So they didn't really record a lot of cases being recorded within schools. Okay. So we'll go to, yes, Dr. Ziambo, over.
Thank you so much. We can now just engage our network. And so we'll do some pause so that they can also participate in this interactive session. So at this stage, we'll ask our network to actually pick the best answer here. And so the question is, which of the following is false about COVID-19? Which of the following is false about COVID-19? True asymptomatic infection is common. 50% will be critical at the time of diagnosis, or children tend to have milder infections than adults. Which one of the following is false? True asymptomatic infection is common. 50% will be critical at the time of diagnosis, or children tend to have milder infections than adults. Which of the following is false? So we would like you to get to pick an answer which is not correct from these choices. And we can see here that we are about 116 participants. So far, at least about 50% have voted. And most of the voters think that B is the correct answer. So we just have another 10 seconds more before we end the poll. Then we proceed. So what we're going to do is that we'll look at the four questions, then discuss the answers after Dr. Kabwe completes his presentation. So thank you so much for participating. Now we move on to the next slide. So Dr. Chanda, please continue.
Thank you, Dr. Kozi. Okay, so let's briefly look at the natural history of COVID-19. So all these I'm presenting from the evidence that have been generated so far from Italy and from China. So what they find in terms of the natural history of COVID-19? So at diagnosis, approximately 80% of the cases were mild to moderate, 15% of the cases were severe, 5% of the cases were critical. In terms of progression from mild and moderate cases, 10 to 15% of these progressed into severe disease, and approximately 15 to 20% of severe disease became critical. Then another aspect to look at is the average times at which these symptoms presented, because this is actually critical in terms of transmission dynamics of COVID-19. So from exposure to symptom onset, it was seen that this took about 5 to 6 days. Another thing to note is that from symptom onset to recovery, for mild cases, it was about 2 weeks. Then for severe cases, it was about 3 to 6 weeks. From symptom onset to death usually took about 2 to 8 weeks. So these are from evidence that has been generated so far at early on in the outbreak. Then there's an issue of the asymptomatic infections. I think we're hearing a lot of people getting sick with COVID-19 and not showing any symptoms. So in China, the truly asymptomatic infection is definitely unknown without serology. And I think one of the reason is early on in the infection, it was quite, it's a challenge to actually have a positive result from the molecular testing, which is the PCR. And an estimated 75% of asymptomatic cases at time of diagnosis soon progress to disease. So that's another aspect that we need to know. So some of the patients that didn't present any symptoms, about 75% progress to actually developing the signs and symptoms of COVID-19. Okay, and then another thing to note is children tend to have a milder disease than adults. So this again has been shown in China and in Italy. Then we look at the virology of COVID-19. So in terms of viral shedding, the shedding is actually highest early on in the course of the disease. And the shedding would actually occur 2 days prior to symptom onset, okay, which means someone would be asymptomatic at least within 2 days of getting the infection. The other thing is they did isolate the coronavirus in stool, but right now there's no evidence if the virus that was isolated through this route was actually viable. So we need more evidence on this one, but again, just to be cautious, that even in our patients that we are seeing, we need to ensure that sanitary issues are taking place, because we don't really know if really the virus which is being shed in stool could actually be a source of transmission. A few countries like Singapore have actually reported about 2 cases of transmission from these routes, but we need more evidence to really see if the virus isolated could actually be cultured and see if it's actually transmissible. So we need to tread carefully on this one. So in terms of how long the virus sheds in mild, moderate cases, it was seen that for the mild cases, the virus would actually be off the system by 7-12 days. In severe cases, it will go for over 2 weeks. And of course, patients who recover can be PCR positive after symptom resolution. And again here, the RNA can still be detected, but again, we still need to see how viable that virus would be. Then we'll look at the pharmacological interventions that were instituted. And by the way, these were done in China and of course, replicated in some parts of Italy. So what did they do? Dr. Kozu can click on the slides. Yeah, thank you. Yeah, so in terms of the 9 pharmacological interventions, we had the universal population measures, case isolation and management, close contact quarantine, suspension of public gatherings, and movement restrictions. So in terms of how these were implemented, so in situation where there were 0 cases, they did universal population measures. For case association management, only when there were some sporadic cases, when they were having cluster of cases. Now, all these were actually done in a combination, including suspension of public gatherings, movement restriction. Movement restriction actually started when they realized actually there was serious person-to-person transmission and the community actually was overwhelmed with this infection. So this is how these 9 pharmacological interventions were done, depending on the severity of the cases within those catchment areas. So let's look at the key experiences again from China. So what did China do to prevent this disease from spreading further in China and of course outside China? So they had these 3 strategies. So the first thing they wanted to do was put up 4 defenses. So those 4 defenses were to ensure that they contain the disease within Wuhan. Second was to ensure they prevent a major disease outbreak in Beijing. We know Beijing is it's a trading a place for the world. The third one was to ensure that they stop the spread of the disease from Hubei to surrounding regions, and of course the fourth was to ensure that the spread of the disease was contained from spreading outside China. But of course, from what we're seeing, this didn't actually happen. Okay, so they put up four early measures. Okay, so early detection, early reporting, early isolation, and early treatment. Okay, so these were the 4 early measures that were in were put in place. Then the other aspect in any disease outbreak is risk communication. How are you engaging the community? Because that was quite key. In one of our interactions with the Chinese expert, in terms of community engagement, one of the things we did ask them, how possible was it that all these measures were actually adhered to by the Chinese people? So one of the things they did actually say was the Chinese people follow rules. So once we tell the Chinese, do this, don't do that, they follow those by the book. And that's how they engage the community. So they explained what they knew about the COVID-19. They explained what they did not know about COVID-19. They explained the measures that they're putting in place. And they identified key people within the communities that they needed to work with to ensure actually they bring this outbreak to an end. And that seemed to have worked well in China. Next slide. Next slide. Okay, so we did talk about those non-pharmacological interventions that China, Italy did institute. So this EPICAVE just shows the timelines at which these were done, of course, divided into 3 phases: the first stage, second stage, and the third stage. We are seeing, I think there's one point where there's that high peak. That's a point where the case definition for COVID-19 was changed. So, there was an upswing of cases. So we are seeing at the point where they put up all these measures, we're seeing actually cases are beginning to get down, and the curve actually was flattened. Next slide. Okay, so let's look at the tailored control measures at varied risk levels that these 2 countries referring to did. So what they do in low risk areas. So in low risk areas, the first thing that they needed to do was strict prevent importation. Okay, so how do we prevent that importation? Of course, we need to look at heightened surveillance at the point of entries. That was actually quite key. Once cases are identified at the point of entries, appropriate isolation centers within the point of entries, for cases that are going to be diagnosed, appropriate screening tools, thermal cameras, and all that. So that was the first thing that you need to do in most risk areas. Then for medium risk areas, of course, you need to prevent importation and stop local transmission. So that should be the strategy. Then for high risk areas, the strategy is to stop local transmission, prevent exportation, and implement strict prevention and control measures. And all these mechanisms that I'm mentioning here, they of course depend on the prevailing epidemiology of COVID-19 in that specific locality. Next slide. So we look at the control strategy for imported cases. So the entry quarantine, I've already talked about this. So health declaration. So you need to ensure that all visitors that are getting into that locality are screened, they declare their health. There are some forms, questionnaires that are screened, that they fill in. Of course, temperature screening are quite key. Of course, for temperature screening as well, this is quite subjective because as we are seeing more and more asymptomatic cases there, which of course right now difficult to say because we don't have serology. But with this one, actually, you might actually miss as many cases as possible. So you need to ensure that you just have that high index of suspicion following the case definition that you are using. Medical examination for suspected symptoms, quite key. And then, of course, once a case is identified, you need to ensure that these cases are transferred to a designated hospitals. You need identified hospitals, identified transport systems, identified trained personnel that are going to follow all the infection prevention control protocols to ensure actually they don't pass on infections themselves as they transfer these suspects. And of course, for those that are not showing any symptoms, of course, you need to ensure that that you send them to government-designated hotels or isolation facilities for medical observation. Then what was their policy for isolation of travelers? So what they did is for home quarantine or in designated hotel, these suspects needed to stay there for close to 2 weeks. And of course, this is dependent on the risk evaluation and of course of the local policy of that as a specific catchment area. And this was regardless of whether it was a domestic individual or it was a foreigner. So these measures applied to everyone. Next slide. Okay, so we'll look at the case stratifications. So what do you call a case that is described as mild? So mild cases, the clinical symptoms, here there are no signs of pneumonia on imaging, and in some cases there are no symptoms at all. Okay, then in moderate cases, of course, so we shall some fever, respiratory symptoms, and radiological findings of pneumonia. That is either on a CT scan, MRI, or a chest X-ray. Then for severe cases, cases meeting any of the following criteria, of course, there's respiratory distress that is greater than 30 breaths per minute, when oxygen saturation is less than 93% at rest. Then, of course, we have the issue of the arterial blood pressure, fraction of inspired air less than 300 millimeters of mercury, and of course, cases with chest imaging that showed obvious lesion progression within 24 to 48 hours. So whenever there was rapid change in the infiltrates of the chest, then you know that I think this case is definitely a severe one. Then for critical cases, these are cases that made the following criteria. So where there was evidence of respiratory failure requiring mechanical ventilation, shock, and with other organ failure that required the critical care in the ICU. Over to you, Dr. Ziambo.
Thank you very much, Dr. Kabwe. We get back to our network, and so we are going to relaunch the next question. Sorry.
Yeah.
So we have question 2, the next poll. So which of the following is not true about the predictors of severity in severe infection? Which of the following is not true about the predictors of severity in severe infection? Progressive increase in lymphocytes, progressive elevation in CRP and interleukin-6, gradual increase in lactic acids, or rapid increase in pulmonary infiltration. Which of the following is not true about the predictors of severity in severe infections? A, progressive increase in lymphocytes, progressive elevation in CRP and interleukin-6, gradual increase in lactic acid, and then rapid increase in pulmonary infiltration. Very interesting questions we have here. We've gone a little bit micro level today. And so I can see that we don't have much participation. Only 30% people have voted. I'm sure we are all eager to learn about the predictors of severity of infection. And these do actually predict as well on morbidity and mortality. Okay, so we have run out of time. So I will end the poll. Thank you very much. Dr. Kabwe?
All right, thank you, Dr. Ziambo. Yeah, so we look at the early prediction of severe cases. So what were they seeing in China and in Italy? So in both countries, the predictors of severe cases was similar. So what did they see in adults? They saw progressive decline of peripheral blood lymphocytes. They saw progressive elevation of inflammation biomarkers, that is the C-reactive protein, the interleukin-6 D dimers. So all those, there was actually some elevation in those inflammatory biomarkers. They saw a gradual increase in lactic acid. there was significant enlargement of pulmonary infiltration in a very short period of time. So these were a predictor of severity in terms of progression in these patients. Then for children, the predictors for severe cases, there was of course tachypnea, there was a child is not active, lactic acid also increased gradually. There was a bilateral or multilobar infiltration, and this was actually rapidly occurred. Then for infants less than 3 months with these comorbidities, there was congenital heart disease, bronchopulmonary dysplasia, deformities of the respiratory tracts, abnormal hemoglobinemia and severe malnutrition, or immunity issues of immune deficiencies, including use of immunosuppressants. The other thing I need to note here is for China, the issues of HIV patients. For them, for the patient that they saw during the period of the outbreak, there were very few in terms of coming up with anything significant that you can talk about in terms of the progression of disease in the HIV positive population. So on that one, I think from the last update that we had with the Chinese expert, I think they only saw about 30 patients who are HIV positive, and those the conditions actually were mild to moderate. Yeah, so there was nothing significant in terms of how the HIV population were affected by the COVID-19. There wasn't a lot of data coming in from China on that one. Next. So let's look at how they manage the patients and the close contacts. So what they did is any suspect case was isolated and reported as soon as possible. Of course, they used the case definition that informed them on what suspect case is. And I'm sure in our setup, I know there are case definitions that have been put up, so we need to ensure that we follow those case definitions as much as we can. And of course, this case definition are bound to change depending on how the epidemiology of COVID-19 evolves. Patients should be transported safely and if it's needed. So when we say safely, it means in a designated vehicle, as an ambulance, trained personnel to transfer, and we expect that this personnel were trained on how to do this transfer safely. We need to ensure that appropriate personal protective equipments are available for transferring these patients safely to either isolation centers or the designated hospitals. Then all close contacts were quarantined either at home or within identified isolation centers by their respective government. Next slide. Okay, so we continue with patients and close contact monitoring. So in terms of the suspect again, so they ensure that the isolated patient was treated in single rooms, right? So again, in our setup, this could actually be a challenge because you really need a lot of space. And I think if we recall, China actually did build, I think, big hospitals within a record, is it 7 days or 2 weeks or so, so that they increase space for management of patient. But even in that situation, they still had challenges where they could just cohort patients with similar symptoms together. So ideally, what they did was you isolate and treat in single rooms. Then for those in isolation, they were discharged upon having 2 consecutive negative PCR within 24 hours. And of course, negative antibody test after 7 days since onset. So this one for the antibody test, I think it was just in trial phase. They didn't really use this much. They really depended on the PCR negative test with 24 hours apart. Then for confirmed cases, isolated and treated with other confirmed cases in the same room. So they did cohort these patients. For cases were admitted to ICU as soon as possible and put on ventilators. Next slide. So let's look at the general treatment. So basically, the first thing that you would want to do is to ensure you help a COVID-19 patient to to fight the virus within themselves. As any of these respiratory viruses, it's self-limiting as long as you do support the patient. So what do you need to do in terms of this supportive therapy? You need to ensure sufficient caloric intake for the patients. All right. So if they are severely sick, of course, you can find ways in which you can give enteral feeds. You need to ensure water and electrolyte balance. And again, here you need to tread carefully as you're giving water, because especially patients that develop acute respiratory distress syndrome, water. If you don't give water properly, that could actually worsen their condition. So you need to tread carefully as you try to stabilize this very sick patients with ARDS with fluids. So close monitoring of vital signs and oxygen saturation. Of course, you need to repeat such tests as blood and urine, the CRP, other inflammatory biomarkers. So you need to ensure that these are either going to the normal levels or whether they're going to waste a level so that you can intervene in time. And of course, you need to ensure that you do chest imaging to see the progression in terms of involvement of the lungs. I think as earlier on, we mentioned that where there could be rapid development of this infiltrate. So you really need to monitor that by doing chest x-rays. Then you need to ensure that oxygen therapy is available, of course, by a nasal cannula, either by oxygen mask. And here the oxygen can be delivered by a high flow oxygen. Then, of course, there's issue of mechanical ventilation. So non-invasive ventilation for at least 1 to 2 hours. There's invasive ventilation, which involves lung protective strategies. So these includes to ensure that there's a low tidal volume of about 6 to 8 mL per kg ideal body weight. I'm sure colleagues working in ICU, critical care areas, I'm sure this is their baby. And you need to ensure that you have an appropriate positive end expiratory pressure. So you need appropriate PEEP, because what you don't want is to ensure that the alveoli collapses. So you need to really maintain a level of air within the alveoli, because if they open, close rapidly, that could actually furthermore inflame the alveoli. So you have appropriate PEEP so that is avoided. And right now there's a talk of prone. I can just get back a little bit. So there's an issue of prone ventilation, which is being talked about. I think one of the findings they did find in Italy, and maybe another example from the US, is what they now call happy hypoxia. So happy hypoxia, probably where a patient is hypoxic with an oxygen saturation of under 60. Okay, and this patient is able to even talk, be able even to do 1 or 2 things on their phone, so known as happy hypoxia. So those patients sometimes you just need to flip them on their tummy, and of course give oxygen. And this sometimes actually avoids the need for mechanical ventilation. We know mechanical ventilation also has the downsides to it. So prone position ventilation, especially in low limited settings, actually one way that is recommended for patients that need this kind of support. Next slide. So let's look at the available antiviral therapy. I think one key thing to note that right now, as of today, there is no effective treatment for COVID-19. However, some antivirals were tried in China. So one of those that they did use was alpha interferon. So they gave about 5 million international units equivalent dose. And of course, this was nebulized with 2 mils of a normal saline twice daily. The other antiviral that they tried to use was lopinavir, combination of lopinavir and ritonavir, about 200 milligrams. For this one, actually, they found no benefit in terms of no benefit from standard care. So the outcome were similar in patients that didn't receive the lopinavir and ritonavir. So basically, nothing much to talk about this combination, because there were no benefit from this one. chloroquine phosphate, I know we've been talking a lot about the chloroquine phosphate. So some of the studies that have come out, actually, there were some other studies that were done in the US, and of course, use of chloroquine has been associated with increased mortality. So they also used Abidol to treat adults. And of course, there's a talk of convalescent plasma treatment. Here again, there's no evidence currently of its efficacy. And one thing to take note here, most of these antibodies that they are being produced, the IgM, IgGM, and IgG, and IgG. Right now, we haven't yet looked at a study that has shown the neutralizing activity of these antibodies. So again, too early to say whether this convalescent plasma is actually working, or maybe someone could actually have a long-term immunity after getting COVID-19. So more and more studies are needed to really know, if you could have reinfection or not, because so far we haven't really found these neutralizing antibodies. And there may be an example from the MERS and SARS outbreaks. One of the things they found there was antibodies could actually be produced, but I think within 2 years or so, usually they all disappear. So those are things that are happening. So COVID-19 right now has got no expert, and a lot is happening. So this presentation we're doing today, tomorrow, actually, it could be something else. I pause here for the poll question. Dr. Ziambo, over.
Thank you so much. We're getting a lot of information. I think you've done a good job on this presentation so far. I'm sure the network agrees with me. So we have another question here. Treatment for COVID-19. Which of the following is true? A, there's no vaccine. B, Remdesivir can definitely treat COVID-19. C, Hydroxychloroquine can definitely treat COVID-19. And then D, Azithromycin, treatment of choice for COVID. So which of the following is true? We are quite a number on the network, about 167 connections. And so we are hoping people can participate and make this session interactive and think and choose which one is the best answer. So far, most people think A is the best answer. Nobody thinks hydroxychloroquine. Oh, actually, somebody thinks hydroxychloroquine is one of the answers. Then we have azithromycin as well, being selected. Okay. So we have a few more seconds for our polling before we end the poll. This is about 65% of vote so far. So thank you so much. We will stop the poll here and continue with the presentation. Dr. Kabwe.
Thank you. So recently, I think we've been following the news or other online publications. We are seeing some promise in this Remdesivir as an antiviral against COVID-19. So this is not a silver bullet to treat COVID-19. Of course, there's some hope in there. But so far, what is showing is that it has reduced the time of recovery from those that have got severe infection. I think it cut the number of days to about 4. So in terms of the mortality effect of Remdesivir on mortality, in those with severe COVID-19 infection, not known. But of course, it has reduced in terms of the number of days someone with severe disease can go with the disease. So some hopes in terms of Remdesivir as an option for antiviral. And again, as I say, not a silver bullet yet. And of course, there's no proven effective vaccine against COVID-19. A lot of vaccines are on trial right now. So we hope for the best in terms of any vaccine being developed. Over to you, Dr. Zembo.
No, thank you very much. The last poll. So let's participate to prevent healthcare workers associated infections. Healthcare worker associated infections. Administration should ensure there is a focal point person to check compliance to PPE and IPC procedures. Is that true or false? Is that true statement or false statement? To prevent healthcare worker associated infections, administration should ensure there is a focal point person to check compliance to PPE/IPC procedures. Nearly everyone actually says it is a true statement. Okay, thank you very much. But 60% have voted so far. Okay, so we are going to end the poll. Continue with the presentation. Dr. Kabwe?
All right, thank you. So let's look at how can we prevent these healthcare workers associated infection. I think this is actually quite cardinal, as health workers to understand this aspect, because if more and more healthcare workers are getting infected, then we can actually lose this fight. So we need to ensure that our frontline are actually protected. So here, we need to ensure there is a triage, okay? So in terms of triage, it means you need to put up a system in place that will ensure you're going to determine which cases have got the signs and symptoms of COVID-19. So the index of suspicion needs to be very high among the healthcare workers. So for this triage, you need to ensure that you put it at probably the entrance of a facility, okay? And you need to put a trained person that is trained and of course provided with the latest case definition depending on the epidemiology of the COVID-19 that particular catchment area. So you need to ensure a high level of suspicion. Right now we're seeing, COVID-19, from the results that are coming in back home, we are seeing, more and more cases coming out from within our communities. Some, of course, with connection to known cases. Some, of course, with no connection to the known chains of transmission. So we need to treat each and every case right now as a possible case of COVID-19, okay? So this early recognition is important to avoid infecting ourselves as healthcare providers. Okay, and once you do this early recognition, you're going to ensure that there's source control. Okay, so source control means you lump these patients with suspected COVID-19 in one place, thereby, of course, reducing the contact between yourselves and the patients. And again, this, and of course, by doing this, you ensure that these patients are provided with the surgical masks that they need to wear, okay? Thereby as well protecting yourselves from getting this infection. And of course, you need to ensure that you yourselves put a face mask whenever you are in contact with any patients. For me right now, I would say treat each and every person that you see as a COVID-19 patient right now, anyone who comes to the health facility, okay? There is a lot of asymptomatic cases, and I think that has been shown. A lot of studies have shown that people that have actually contracted the COVID-19 end up with severe infection, actually got the infection from a person that didn't show any signs and symptoms. So we need to tread carefully right now and ensure that we protect ourselves at any time when we're in close contact with a mask. And it's good that we've got recommendation of use of mask for everyone. So that is actually a welcome move. And this would actually even help to ensure that our healthcare workers are protected. So let's look at the standard IPC measures that our healthcare workers need to perform. Okay, so of course, the normal hand hygiene that we've been accustomed to, respiratory hygiene. So either you cough in your elbow, you use a tissue, and of course a mask if you have signs and symptoms, or your patient has got signs and symptoms of COVID-19. And of course, these other standard practices that we always do: injection safety, safe waste management, proper linen, environmental cleaning. And for environmental cleaning, okay, I think one of the ways this COVID is spread, of course, is via droplets. And a lot of studies that have been done, the transmission studies, they've actually shown that this virus can actually stay for a longer time on steel, it can stay on cardboards, it can stay on linen, on door knobs, bathroom scales, bathroom taps, okay? So all those areas, we need to ensure that we disinfect them as frequently as possible. That should be routine every time. You don't need to be in a COVID-19 to do in a COVID-19 treatment center to do this. This should not be routine, okay? As we do those dam dusting and all that, can we target frequently touched places by either yourselves or the patients? That will minimize the risk of getting infections to ourselves. And of course, we need to ensure that we sterilize all equipments that the patients are going to use. Okay, so if we're using a thermometer, if we're using a stethoscope, anything that is within the vicinity of the patient is a possible hazard, and you need to ensure that you clean it. And of course, you use the normal solutions that we've always used for disinfection. I know there are all those 3 buckets that we use, cleaning, disinfection, installation, all those. So we follow those standard things that we do. And this time around, we need to ensure that we abide by that. Let's follow the protocols that are there. Any gap in these things will actually lead to our healthcare workers getting infected. So we need to follow these standard measures by the book, okay? Then of course, we need to put up administrative controls. So administrative controls imply you need to ensure there's availability of PPE. Okay, so availability of PPE means, of course, a clean, long-sleeved gown. You need a surgical mask. You need goggles, okay, or a face visor. You, of course, if you are doing what are known as aerosol generating procedures. So aerosol generating procedures are those which would actually encourage, these small particles of fluids containing COVID-19 to actually, be disseminated in air. Okay, so you need to ensure that when you are performing these procedures, you need to ensure that you put an N95 mask. And for N95 mask, you ensure that you fit test it. Okay, if it's not fitting, don't attempt to go and do this procedure. Don't go and attempt to go and see any patient. If you don't have proper PPE, don't be a hero. Okay, and this should be clear. If you don't have appropriate PPE, don't be a hero and try to see a patient or do a procedure on a patient. If there's no proper PPE, you need to abandon that, okay? Because we don't want you to get sick at the end of the day, all right? So ensure availability of PPE and abide by all the protocols on how to don and doff the PPEs. You need a focal point person to check compliance of PPE. Okay, and one of the hospitals that in Chanda, okay, they're so close to about 30,000 or so patients, but none of their healthcare workers got infected with COVID-19, and I think that was the first in one of the areas in China. And one of the things they did talk about was the issue of compliance. So they needed a person that was regularly checking on how everyone was donning and doffing the PPE, how they are observing the hand hygiene, how they are putting up either the N95 mask or the surgical masks, okay? So someone should be on the lookout, okay? Even when you are putting on a PPE, you need what is known as a PPE buddy, okay? So if your PPE buddy is your fellow healthcare worker, who ensure that, when you put on that PPE is adequately donned, and it gives no room for infection. So let's have PPE buddies. Let's identify within our facilities someone that can be ensuring that compliance of PPE is done. And of course, ensuring that there is availability of PPE. And again, on PPE, please, healthcare workers, you are not supposed to put on cloth masks. Cloth masks are for the community. we need all these masks to be used among healthcare workers. So as I said, don't be a hero. If you think about a face mask, I mean a cloth mask which can protect you and go into an infectious area, then you'll just be doing harm to yourself. So let's avoid this. So if you don't have proper PPE, don't work. Inform your supervisor that you can't see any patient without the proper personal protective equipment. Because what's the point of you going there, getting ill, and of course, we're going to reduce on the much needed workforce right now. So we need to ensure that ourselves. And I think from the example from Shanghai General Hospital, the compliance focal point person actually helped a lot. Okay, in some instances, there were even 2 or 3. Okay, some were even those that were actually within the treatment centers to ensure that they look at each other to ensure that they follow all the protocols that have been put in place. Okay, so we need to ensure that this happens in our facilities, just within the same workforce that we have. I think one person should be able to see how everyone is actually putting on these PPE, and of course trainings. We need trainings for our staff on how to put on PPE, the basics of PPE. Trainings actually key in terms of administrative controls. So we need to ensure that we take care of ourselves. Let's not be heroes. Let's demand for availability of PPE. Let's ensure we've got PPE bodies that are going to look at it. Look at how we are donning the PPE, how we are doffing the PPE. Let's ensure we are compliant. Okay, avoid all these gadgets, phones, computers when we go to places that are highly infectious. Right now, unless it's really needed, leave all these things probably home, okay? Because studies have shown that even on a computer, mouse, phones, all this can harbor the virus for a long period of time. So we need to protect ourselves as healthcare workers. Let's follow the standard precautions. Let's identify focal point person that will ensure that we're complying to the PPE, and let's demand for proper PPE. There's no PPE, let's not be heroes. Over to you, Dr. Zambo. Thank you.
Thank you, Dr. Kabwe. I can hear and feel your passion about healthcare safety, and I think WHO Tedros has been singing and has been emphasizing the need for healthcare workers' safety. I think it's actually primary. It's top on the list. Thank you so much for emphasizing that. Yeah, we appreciate your availability and to be able to share this very important presentation with us. So we'll open up for a few questions since Dr. Kabwe has, I think, has done quite an exhaustive job, and we'll ask Matero to prepare their case. So we'll just have a few questions, and then we'll move on to the case presentation so that we can have an opportunity to ask questions at the end. And so I have some questions that I picked out from the chat box. Maybe Dr. Kabwe, you can pick this one, or any other experts here. I know we've got, I've seen Jonas is here, Dr. Mpeta, Dr. Sivile. When is seroconversion to negative from positive? When does this happen? There's a question. After somebody is diagnosed positive, how long does it take before they stop shedding and they seroconvert to negative? Then the other question is, maybe to you, Dr. Kabwe, is how is Zambia doing in its response compared to the China response? How are we faring? I think you laid out quite a good response plan that China made, and how are we doing as Zambia? So you could start off with those two questions. Thanks.
Okay, thank you. I think my colleagues, I think Dr. Seville, Dr. Mpeta, Dr. Foloshi, I think they're all here. And yourself, Dr. Kozia, I'm sure you can chip in terms of issue of antibodies. So the question is, how long do antibodies take to clear from somebody who's infected with COVID-19, if I got it right?
Yes.
Okay, so in terms of antibodies, so the evidence that is currently there, what they are finding is, if you do an antibody test early on during the infection, usually it was found to be negative. The first 2 or 3 days was found to be negative. Then the sensitivity rose close to about 70% after the 5th day of the infection, and about 7th day of infection. In some studies have actually shown that 100% of those actually did develop these antibodies. So that's immunoglobulin M and later immunoglobulin G. IgG. Okay, so at some point they will actually show up at the same time, and in some it was IgGM, then later on IgG. Then in terms of how long these antibodies will last, for that one, I haven't seen any evidence to that effect. And are these antibodies, to add on, are they protective? Again, we haven't had so much evidence to that respect. But if we compare with the similar viruses like the MERS and the SARS viruses, it was shown that, you know, the IgG would actually last for about a year in SARS, then in MERS goes about 2 years, and then they disappeared from the system. Maybe someone can add on that.
Thank you very much. A good response. Any comments one here about that? Dr. Seville? Okay. Dr. Kabwe, maybe you could also
Yes.
Give your impression on how we are doing with our response in Zambia.
Okay, thank you. So how are we doing in terms of the response in Zambia? Okay, so we are actually doing well as a country. I think, you know, for COVID-19, as I say, no nation is an expert. I think we have seen in developed countries, you know, where we thought, you know, they already handle this well, but I think we're seeing what's happening, you know, the case of Europe, the case of the United States. So it's been a challenge for everyone. You know, it's been a learning phase. And I think one of the reasons is, you know, how, you know, the virus was, able to spread so quickly, and, you know, leaving everyone shocked in terms of their preparedness. But generally, looking at the interventions that have been put in place in the country, I think we're on track. The last time I was in Zambia, in passing through the airport, and there was quite a robust screening that was taking place. I identified isolation centers, transport mechanism, everything was in place. But of course, with COVID-19, you can't be perfect, because I know that's what everyone probably would want, a perfect response. I don't think there can be a perfect response, but I think you do whatever possible that you can to ensure that actually, you know, you control the spread of COVID-19. Of course, the worry right now is, of course, of the community transmission that we are seeing. And of course, you know, someone actually did argue that, you know, if this case could actually be already in the communities, and majority actually, you know, they don't even have any signs and symptoms. But as we know of COVID-19, there's evidence that even talking, like I'm talking right now, I'm throwing all these, you know, shedding all these viruses if I had COVID-19. Okay, so we are learning more and more about this virus, you know, but I think things are in place. So as you test more, you expect to find more. If you don't test, you don't expect to find cases, okay? And sometimes finding more cases sometimes doesn't mean there's progression of the disease. It's still those cases that are within the community, but were just not identified, okay? So yeah, the response is on track, and you know, looking at just even the picture generally on the continent, I feel we are.
Thank you so much for that. So maybe we should look at our poll questions. Where we had some poll questions that we needed to run through again for the sake of our participants. So I'm going to relaunch the question one. So I'm sure most of you may have noticed that this question says, which of the following is false? And there's more than one answer that may be correct here. So let's vote. True asymptomatic infection is common. 50% will be critical at time of diagnosis. And children tend to have milder infections than adults. So we can pick which one is the best answer here. Okay, I think I'll end the poll and then we may discuss the answer. So this is how we voted, and this is how we picked on the answers. So, Dr. Kabwe, would you like to run us through?
All right, thank you, Dr. Ziambo. Yeah, so here, okay, I'll start with the last one. Children tend to have milder infection than adults. Of course, this is both aspects, both actually have a milder illness, but of course, in most of the children, they had more milder infection compared to adults. 50% to be critical at time of diagnosis. I think this is clearly false. Then true asymptomatic infection is common. So for this one, we said actually, you know, initially it was these true asymptomatic infections were unknown. And why were they unknown? It was because of the fact that there was no serology. Serology would actually tell you, serology would actually be a good surveillance tool so that you know the number of people that are asymptomatic. But with the PCR being the standard, the gold diagnostic criteria, then it's really difficult to really say these cases are truly asymptomatic. But we know they are there, but we need serology to ensure that we know that these cases are there within the communities.
All right, thank you so much. So we'll move on to the next. So we'll take it that the answer here is A and B. So question 2. Question 2. Which of the following is not true about predictors of severity in severe infections? So we've got some predictors, I think, that Dr. Kabwe ran us through. I think they're here now. Which one is not true about the predictors? Progressive increase in lymphocytes, progressive elevation in CRP and interleukin-6, gradual increase in lactic acid, or rapid increase in pulmonary infiltration. Which one is not true? Okay, so I think I'll end the poll for this one. I've noticed that we do have a lot of comments in the chat box. We are going to discuss some of the comments we're going to share and bring them up to the rest of the panel and the rest of the network. Dr. Kabwe.
Thank you. So which of the following is not true about the predictors of severity in infection? So I think from the presentation we did hear that you know, some of the markers for the severity of infection was a rapid increase in pulmonary infiltration, which is correct. Of course, there was also a gradual increase in lactic acid. Of course, there was elevation of the inflammatory markers and an increase, a decrease in lymphocytes. So A is wrong, the rest are correct.
Thank you very much. Okay, go to question 3. Treatment for COVID-19. Which of the following is true? There is no vaccine. Remdesivir can definitely treat COVID-19. Hydroxychloroquine can definitely treat COVID-19. Azithromycin is the treatment of choice for COVID-19. Okay, which one is true amongst this? All right, I am going to end the poll. Thank you very much. Dr. Kabwe.
All right, thank you. So treatment for COVID-19, which of the following is true? Okay, so of course, we know that there is no vaccine for the management of COVID-19 right now. So this is true, there's no vaccine. Remdesivir can definitely treat COVID-19. As I said, there's no silver bullet yet. Yes, it has shown a lot of potential in terms of reducing the number of days someone will be with a severe illness. In terms of its impact on the mortality, this is also not known. So right now, yes, it has shown some promise, but not a silver bullet yet. Hydroxychloroquine can definitely treat. Okay, thank you.
Yeah. And the last one, to prevent healthcare worker-associated infections, administration should ensure there is focal point person to take compliance to PPE and IPC procedures. This one seems obvious, Dr. Kabwe.
Yeah, this is obvious. Yeah.
All right, thank you so much.
Okay.
All right. So I think I'll just end this poll and I'll invite Dr. Katamba to prepare as we share their case. So we have got another case that the team in Matero had actually experienced, and they would like to share with the network. All right. So Dr. Katamba and Dr. Kashweka. Are we ready? Yeah. Can you see them underneath? Yes. Matero, are you able to proceed with your presentation?
Yes, thank you very much, Dr. Ziambo. We are going to present a case, but before we present, I want to give a background to what is happening at Matero Level 1 Hospital in terms of a response to COVID-19. So the hospital conducts screening for COVID-19 every day at triage. The triage is placed just near the gate, not far from the gate. That's where we place our triage table. And there you have two nurses working together with other support staff. They use the screening tool that was provided to us by ZNPHI. So this screening tool is a short one. It has a patient identity and other demographics. Then you go to screening questions, about 4 of them. The question number 1 is about fever, and then number 2 is about other symptoms, including sore throat, cough, running nose, shortness of breath, and diarrhea. So if the client screen positive to any of these questions, they are sent to the respiratory center that is just outside the OPD, where they get swabbed. So eligible clients get the samples collected, and at the facility we have a number of things that are happening. We have hand washing facilities throughout the facility, at the gate also, at the triage table. So at the triage desk, I've already mentioned, you have 2 nurses working there. They use the screening tool. They also do have face masks. They keep some face masks for some clients who do come and present with respiratory symptoms. Those are coughers. If they do not have mask of their own, they are given mask right there at the triage, and they are sent for swabbing. So that is what is happening at level 1 material in terms of COVID response. I'll now hand over to Dr. Kasweka to present the case. Next slide, please.
Please go ahead.
Good afternoon, network. Dr. Kasweka, TBH Medical Officer from Material One Hospital. Allow me to go through this short presentation. This is a male client. Excuse me, Dr. This is a male client, age 63, who is a resident of Material. Is a HIV positive treatment. Was initiated in 2013 on DDF, lamivudine, and nevirapine. The later on was switched to TOE. That was last year in January. Currently is on second line. He failed on first line treatments and is on atazanava, lamivudine, and AZT.
Dr. Kasweka, we can't hear you. Dr. Katamba, are you together with Dr. Kasweka? Hello? Matero, are you still?
He was pale and he had no edema. The chest was clear. CVS S1, S2 were regular but tachycardic. The other men were soft. For the vital signs, the temperature was 36.4 degrees Celsius. The BP of 128 over 66 unit of mercury. The pulse was at 100 beats per minute and 80 breaths per minute for respiration. So, conveniently, we decided not to load a lot of information on management of this case, because we didn't want to shift the attention from the current context. As lab, in 2015, we had a 64 count of 197, and early this year, on the 17th of January, viral loads were at 3,906 copies per milliliter. Then on admission, that was on the 16th of April this year. HP was 2 grams per deciliter. And the FIFO count was 54 cells per microliter and 30 copies per milliliter as a viral load. It tested positive to RDT, and it was being managed for severe anemia and severe malaria. So this man didn't present any, he didn't qualify for as a case definition for COVID, but was swabbed review of active case surveillance. The result came on 22nd of April, and it was positive for COVID. And the same day it was transferred to isolation center. Again. Next slide, please. So we had 2 questions for our presentation. The first one, since some clients are infected and they are not symptomatic, they present to care for other ailments, how can we best handle patients to prevent facility-based spread of SARS-CoV or COVID-19? That's the first question. Second one, how do we restore the confidence of healthcare workers who feel they are at constant risk of acquiring COVID-19? Those are the 2 questions we came up with. Hand over to Dr. Zambia.
You've been able to share with us this important case, and which has got a lot of learning points that have come out, and it particularly, and it speaks very well on protective personal protective equipment. And I think one of the comments made in the chat box by Professor Mano Makasa has been that Zambia, we haven't done very well, especially when it comes to training healthcare workers, as well as particularly also provision of PPEs. And I think this case seems to bring out those issues as well. So there are 2 questions here that I think the material team is concerned about. Having attended to a male who was on treatment for ARVs, HIV positive, and apparently came in with symptoms not suggestive of COVID, but ended up having severe malaria and severe anemia, and through active screening was found to be COVID positive, and was then sent to the COVID center. So the team has got these concerns. So we want to invite any comments, any clarifications, and on these questions that the team has posed this network and the forum. So we open up now for any questions that the network would like to.
Hi, Dr. Ziambo. Can I?
Dr. Kabwe, you would like to get some clarification?
Yes, Dr. Ziambo.
Okay. Please go ahead. You may proceed.
Yeah, maybe to just help in responding to the first to the questions.
Okay, no, before you do,
Yeah,
we'll ask you to come in a little later.
Okay.
Let's get some feedback from the rest of the network.
So, Chair, just to clarify, may I?
Please go ahead, Prof.
Yes, please. I think you've done a great job. Like you say, the presenters and the response so far has been good. But of course, like you said, it can never be perfect. So there are some small lacuna where we feel that we could do more. And this is to do with the management of the other patients that are not presenting as COVID patients, and they are presenting to other facilities other than COVID centers. The case in point being the UTH where I'm based. So we have to attend to, as you know, we have scaled down everything else as part of our contribution to the response, and rightly so. But then we have to maintain the emergency and essential services. And as far as surgical services are concerned, even if we were guided by our colleague that we shouldn't try to be the hero, but this is our life. We never try to be heroes, but we can never walk away from an accident victim that's bleeding in our facility, or a mother in difficult labor that's going in, that's obstructing. We are to do something, and we have to do something, and we've been doing something. Unfortunately, this COVID also has the asymptomatic patients that may present to us as accident victims. And so, yes, we're not trying to be heroes. Yes, we try our best to self-protect, but I think as a country, we can do more. If we can train those that have to attend to these emergencies. Our surgical teams have not totally been trained, even on how to put on a personal protective, gown. They haven't been trained on that. We've done the previous, we do, infection prevention in theater and stuff like that, but it's kind of different from this. You know what I'm saying? And so there's need for us to at least train and upgrade the skills as far as prevention is concerned, so they can manage, even when we're managing cases that come to us, we manage them with, some kind of self-protection. And then the availability of these same PPEs. I mean, we only see them with the paramedics in the triage room. Even they don't wear them all the time. Sometimes they don't have. So the availability of those things are a problem. If we're going to maintain these emergency health services, please, can we train the responders properly, and can we give them the few PPEs? There are not too many. We can do this. Otherwise, we'll be spreading infections to other patients, and we'll be taking them home. Thank you, Chair.
Thank you so much, Professor Makasa. I think you somehow also you've responded to actually their second question, that how do we restore the confidence of health workers who feel they are at constant risk of occurring infection. I think you've just hit the nail on the mark. You've emphasized that as admin, you probably need to make sure that the PPEs are available. I think that will give the health workers some sort of confidence. So I will not be very preemptive. I would like to have as many people on the network participating and airing their comments. I would like to pay particular attention. We've got Dr. Ndele on the network, and we just want to recognize you because of how far you are calling in from this call. Could you just say hello to the network?
Thank you very much, Dr. Zambo. Hello, everyone. This is an excellent presentation. Sorry, I joined late.
No, thank you very much for joining us. Okay, so there's another hand, Dr. Mpeta, and then we'll have Agri. Please go ahead.
All right, thank you very much. And I think I just want to make a comment on Professor Makasa's submission. Yeah, it's very important observations that he has made, and especially on the scaling down of most of the services, not just in surgery, and I think even in medical wards as well. And I think it's important to appreciate why this was done, and we know that in anticipation of escalation of cases, we were looking at how best can the healthcare system in Zambia respond. So in trying to make it resilient to the anticipated number of cases, it was decided upon that it's best that we scale down on some of the services so that we can create space for the COVID. Of course, so far one can argue that the number of cases we are seeing are a few, but remember that in any pandemic, epidemic, there's always models of predicting the number of cases that you anticipate. And the fact that we haven't seen the numbers that we anticipated does not mean that we are safe until we see that the peak of the cave has been reached and we have successfully managed to flatten it. So I understand the frustration and I think it's affecting all of us in that you know that the HIV program has been running so well, and scaling up of services definitely might have an impact on it. We are trying to see how we can quickly come up with a way of, restoring some of the services, especially the critical ones that most patients will need. Secondly, I would like to comment on bringing on surgeons for training, and I think this has been the emphasis on my side as a case lead in this COVID training. And I think the plan was to actually kind of do a phase up approach, where we start, of course, with the first, likely responders to this COVID, and then we start scaling up and eventually involving all healthcare workers in the trainings. So we started, of course, with medicines. We know that most patients, of course, affected would have presented to medical wards first. And then we look at the other critical areas like pediatrics and OBGY and surgery as well. So it's a kind of, a phased up approach in trying to engage. So the next phase definitely is going to involve the surgeons, and we have to ensure that they are all safe. Now, with regards to the point I think Dr. Kabwe made in the presentation and mentioning specifically that you shouldn't be a hero, I think it's important to look at it from the point where he was trying to say. So this is a patient who come with all the symptoms of COVID, and then you do not have the appropriate PPE and you unnecessarily expose yourself. And I think this is what is being discouraged. We are saying in such a circumstance, please ensure that you do not unnecessarily expose yourself. Call upon the necessary help that you need, including the provision of appropriate PPE. Now, when it comes to accident victims and any other patients who are accessing the hospital, we have developed algorithms, I think, that should help hospitals and facilities in trying to manage and risk reduction for COVID as regards to transmission among or to healthcare workers. So if we are to appropriately apply this, and as Dr. Kabwe pointed out in his presentation, triage and triage and triage, which is, basically screen first and triage the patients based on the risk factor. And if you have seen at facilities like the UTH, I think we have created such a robust system where different type of patients are being screened, and the moment they are being labeled as suspect, there's an isolation ward which has been identified, and this is the system we're trying to encourage most facilities to kind of follow. So it will depend on the size of facility, and we are always ready to provide the technical assistance with regards to screening and triaging, so that if a patient
so much, Dr. Peter. I know you have a lot.
Yes, yes.
Know,
so if the patient needs to be in surgery, they should have already been screened, and then making sure that with minimal PPEs, the surgeons are going to be safe. And I think that's the route we're trying to take.
Thank you very much. Dr. Member, is that your hand? Agree?
Can you hear me?
Yes, we can hear you.
Yeah. So I just wanted to say that I think that as health workers ourselves, we have a responsibility to make sure that we protect ourselves. I believe that probably some of these transmissions are nosocomial. There's a kid that we're discussing just today that probably would have come through nosocomial infection. And I think that as health workers, we should not just look at the patients that are coming into the hospital, but we should also look at ourselves, that each time we are interacting amongst ourselves, we should also protect ourselves from ourselves. I think that's the first point that I wanted to make, that we will see us seated in the hospital and we are interacting like anything because we trust each other that probably none of us is carrying COVID, but we might be carrying the COVID. And therefore we need to show the same concern that we are showing to the patients with ourselves. The second question, I just wanted to follow up on the case presented from Matero. I see that patient is above 50, is it 55 years? And I wanted to find out whether the patient is diabetic. I also wanted to find out what was the latest creatinine done on that patient.
Matero team, are you able to respond to that, those specific questions?
The cat was not diabetic, so he was it's not hypertensive. For the creatinine, that time he was admitted, we did have reagents for biochemistry. So I don't know if Dave Manawasa did that biochemistry.
So, Levi,
Couldn't be-
Manawasa, are we connected? Is Levi connected? I know Courtyard is connected. They are here with us. I don't know, Dr. Mpeta, would you know if that patient had any creatinine in advance?
All right. So patients who are admitted in the COVID, the lymphocyte, the biochemical studies are based on the severity of the disease. So if this patient developed what was termed to be moderate to severe disease, definitely they got creatinine and LFTs. I'm not particularly because this patient's identity has been masked, so I could not absolutely say if we got or we didn't, unless if I got to know which patient we're talking about.
All right, Dr. Mwemba, we may have to, we may not be able to provide that extra information you needed. Thanks though for asking. Adamson,
And can I just,
yes,
I was just asking that question because this is a patient who's HIV, and obviously we should have had the creatinine done before just to see which profile he is. And this is a patient who's above 50 years old, and so the risk for severe disease is high. That's why I was asking.
All right, okay, all right. Yeah, because you're trying to prepare the network for your next presentation, eh? Adamson Ndovu?
Yes,
Yeah.
Good afternoon.
Please go ahead with the question.
Yes, my question is on, I think I've been seeing a lot of inconsistency in the messages that are being spread in regards to how we're supposed to wear surgical face masks, for example. There are some people who are stating that if you don't have COVID, you have to turn it upside down with the blue facing you. And then if you have got COVID, you have to wear it the correct way, which is with the white facing you. So I wanted to find out, is there any literature to support this, if any has come across this? Because I think my research so far has revealed that there's possibly just one way to wear face masks.
All right, thank you very much. Monze, do you have a question? Your hand is raised.
Thank you so much. Mine was from the first presenter concerning the provision of personal protective equipment. Yes, and the first thing we need to do as facilities is first of all to look at the primary prevention of the infection and to consider every patient who comes to the facility as a possible COVID patient until proven otherwise. So the first things first will be social distancing, of course, and also use of surgical masks, and also to ensure that patients are triaged properly. Thank you.
All right, thank you very much. Dr. Mpeta?
I basically wanted to respond to Dr. Njovu about the correct way of putting on a medical mask or a surgical mask. There's only one correct way, and the correct way is that the darker part is outside and the lighter part is inside. And if we have seen, to avoid this confusion now, we are seeing the mask is being applied. Monze, okay, thank you. The masks now which are being supplied are actually white, so that people, I'm sure they avoid this confusion. But if you ever get a colored mask, the only correct way is darker part outside and the inner, the lighter part, which is the white part inside facing your mouth. And I think probably we could organize another session where we explain why it's so.
Thank you very much, Dr. Mpeta. Dr. Kabwe, would you like to give some of the responses to the questions that the material team had asked?
Yeah, I think they've been well covered. I think in Dr. Mpeta's presentation and Professor Makasa's responses. So I think it has been well covered, but I think just one key is I think to ensure that all patients that are coming to the facilities in this COVID era We just need to have that high index case of suspicion of the accident victims, or maybe patients coming for hypertensive clinics, diabetic clinics. So we just need to ensure that all these are taken as possible suspects of COVID-19. I can give an example of just a recently presentation again from the a Chinese expert from Shanghai General Hospital. So one of the things they had issues was patients on dialysis, for instance. So how did they handle it? Okay, because some of the patients on dialysis had COVID, some didn't have COVID. So what they did was to ensure they put different days for COVID patients and different days for non-COVID patients. So they needed to ensure that the non-COVID care of patients, the non-COVID patients, the care continues because nothing doesn't need to suffer. Okay, but what they did that they ensured that everyone who comes into the dialysis center had their masks on. Okay, so so basically let's ensure that we just have this thing on the back of the mind that everything we are seeing right now is COVID-19. The case definition is no longer people that are in an area with COVID-19 or traveling from a country with COVID-19. The case definition right now is everybody that comes into your facility treat as a potential COVID-19. Everybody, including your close relatives, including your friends, okay? Everybody could have COVID right now. So let's just have that high index of suspicion. Then yes, and of course I do 100% agree with Professor Makasa's presentation on the issue of PPEs, training for colleagues that are working in non-COVID units. I think if possible, I think this is a key item that probably needs to be taken up. I think colleagues that are handling this, Dr. Mopeta and team, I think this is one of the things, because yes, each and every healthcare worker needs to be trained in IPC. That is just to be a minimum requirement. Everyone needs to be trained about the basics of IPC. I think that's it. Over.
Dr. Kabwe, thank you very much for those remarks, and I'm sure the team Matero has picked up one or two things. I know there are quite a number of comments, and we've completely run out of time. And some comments, they're asking whether since there's COVID has been isolated in feces, so they're wondering whether it can be transmitted in farts as well when people fart. I don't know where the science is when it comes to that.
Yeah,
but,
so wow.
You want to attempt to answer that one, Dr. Kabwe?
That's maybe Mopeta can answer that one. Francis.
Well, we've got a comment here. Davis wants to say something.
Well, not relating to the question that Dr.
Okay. Yeah, so maybe I can back up a little bit on what I said about the COVID virus being isolated in stool. So yes, so evidence is there that it's being shed in stool. Actually, what is there is once the shedding in the respiratory droplets becomes negative, the shedding in stool was positive in some of the cases that were looked at in some of the studies that were done in China and Italy. All right, so, but the thing is, I think only one study shows just about 2 patients that they suspect have gotten through this route. But ideally, no study, so far there's no evidence that a viable virus was cultured and could actually be transmissible through this route. So basically, in the case of China, Italy, no, even in the US, I think there's no case that has been identified as being as the COVID that has come through the fecal oral route. So
thank you very much. Thank you very much. Okay, so just a concern here in the house. If you look at the HB for this particular patient that we were discussing in the case, in April on the 16th, the HB was 2, and then on the 27th of April, the HB was 6, and this person was on AZT-based regimen. I don't know what material did in reference to these HB readings, which are very low, and someone who is on AZT. Thanks. Dr. Katamba.
Okay, we can respond.
Yes, please.
So, I think the client was transfused from David Mwanawasa. But here we didn't have blood at that time, so we referred to David Mwanawasa why he was transfused. That was the repeat HB after transfusion. That's why it had gone to 6.
Okay. All right, thank you so much. I'm sure there's a bit more that needs to still be done on this patient to investigate further whether this was chronic anemia or as a result of the severe malaria that he had and the effects of the drugs. So I think we'll need to continue managing and following up this patient. Otherwise, it's been a great presentation, great afternoon. We've left out some questions like Sweden, how come they have not been affected as much despite not having implemented some of these drastic measures that China implemented? That's still yet to be answered. And some concerns regarding turnaround time, that we need to have improved turnaround time and really work on building capacity. I think several times the ministers mentioned that we're trying to make sure that we have another platform for running PCR. And very soon we'll probably be seeing GeneXpert running PCR to try and improve the capacity for turnaround time. Yes, and then also we've had some experiences. Some people have shared that we've got safety officers in their labs, and I think those are very good practices. Thank you so much for sharing. So I think we've done some good measure to this presentation today. Thank you, Dr. Kabwe. Thank you to all those that participated, that were able to make comments. And I've seen a hand finally from Dr. Makawa. We'll just let you, Dr. Makawa, make a comment before we wrap up.
I'm sure people would have wanted to hear the position of the ministry regarding PPEs and a few things that you've mentioned. I'll be very quick. Yes, so in terms of forecasting and quantification, I think when the pandemic started, we didn't have, like most people have said, the value to work with in terms of quantifying for PPEs. And then again, remember the approach we had first was targeted in a sense because we're looking at the patients that were positive. So the initial quantification for PPEs was limited to that extent. However, when we realized that we needed to get a clearer picture, it became apparent that we needed to have a fulfilled type of forecasting and quantification. And I think WHO came on board. We did a proper quantification based on what would see as an epidemiological curve, although it's just an estimate, but we feel that it would answer our needs. And then again, the demand at the international market, as well as the inflow of cargo, became another challenge that needed to be circumvented. So in making a decision of quantifying for more, we wanted to see to it that we front load PPEs in the country. So beginning this week, we'll start seeing shipments come through. We've waited long years. What we've had, we've been centrally distributing to better manage and prioritizing facilities that were recording cases. But I think starting this week, we'll see that change. Once most of the PPEs come in, we'll be able to start distributing on a larger scale. That's one aspect. On the other aspect, the moment you talk about PPEs, the guidelines have gone out to define what it is that PPEs are. We've gone on the ground several times, and half the time when people talk about PPEs, it could be as simple as a surgical mask. In other cases, people will be referring to a diver gown. In other cases, people just want shields and aprons for the purposes of the works that they're dealing in. And this is very important. So even as people are discussing PPEs, we've encouraged that state the actual needs so that we better supply you with what you exactly need. But then one thing I need to emphasize is that we are all health workers. What comes to mind is always protection. We'd always want to envision ourselves fully clad in what we think is the most appropriate or the most protective wear at any one given time. And like experts have said on the forum, let's assess the risk and let's see where we need to have appropriate PPEs. And this is also going to make us better manage what we have in our facilities. But they may also employ units also to have multi-sectoral meetings within the hospitals. It shouldn't be surgery alone, it shouldn't be PIDS alone. Let's find a common ground where we can be discussing these issues in a multi-sectoral approach, because now we are saying that a patient can present with COVID in any department. But then how do we strengthen management for each of these departments? That becomes very key. So finally, as an active point for Dr. Mpeta, I think the response from Professor Makasa and any other units who have not trained, let's give timelines so that they don't feel left out and make a plan. One of the ways we can do it, we've been doing critical care orientation. for the anesthesia team and emergency physicians. We can use those to cascade the trainings for these other departments. That becomes cost effective within facilities like UTH and in other units in other hospitals where we have a few people trained. Otherwise, depending on central trainers, sometimes may incapacitate us because there might be a cost involved. But if we can look at all those who are already trained, they can do local orientations within the hospitals and everyone brought on board. I submit.
What a way to end our meeting today with so much encouragement, and I think this should bring confidence to the health workers out there. Thank you very much, Dr. Makawa, and thank you very much everyone on the network. We've come to the end of this presentation.
All right, thank you everyone, bye.
Bye.